Good morning, Ibavan and Vanakkam. Thank you for inviting me to another SLAUS conference, and sorry that I couldn't join you face to face. I've been asked to talk about the conservative management of lower urinary tract symptoms, and I'd like to start by talking about wise selection of urodynamics and videodynamics, and then moving on to what's conventionally thought of as conservative management of LUTs, i.e. bladder training and pelvic floor muscle training. And I want to encompass as well pelvic floor relaxation. What do the EAU guidelines say? And this is what it says about urodynamics. In male LUTs, invasive urodynamic studies use filling systometry and pressure flow studies to enable shared decision making about a patient's functional lower urinary tract symptoms. And videodynamics adds additional anatomical information about this. This is the most basic of urodynamics, a flow rate and a bladder scan. And I hope all of you have access to this in the units that you're in. This enables a flow rate curve and a post-void residual to be measured. This is the more invasive of urodynamics, and here you can see the pressure transducers and the system used where lines are inserted, one into the bladder, which both enables filling as well as measuring intravesical pressure, and another line inserted into the rectum to enable measurement of the abdominal pressure. And this is in videodynamics. X-ray is used to enable X-rays to be taken. So the patient is laying flat and then tilted after their lines are put in to enable a more physiological fill. And this is a sort of standard trace that you can get from invasive urodynamics. Here is the abdominal pressure, the vesical pressure, and then the subtracted detrusor pressure. And here you can see a phasic detrusor contraction or detrusor overactivity with associated leak and associated symptoms. And what is the recommendation from EAU guidelines about when to use pressure flow studies? And here you can see the various recommendations. And all of these recommendations, the strength rating is weak. And if I can go through each of these individually. So pressure flow studies to be performed only in individuals for specific indications prior to invasive treatment, or when further evaluation of the underlying pathophysiology of LUTs is warranted. So this is where, if you're considering invasive management, should urodynamics be done then? And the evidence for this is weak. How about performing pressure flow studies in men who've had previous unsuccessful invasive treatment for their lower urinary tract symptoms? So those men who may have had a TURP and are having bothersome urinary symptoms. Again, the evidence for this recommendation is weak. How about for those men who you're considering invasive treatment but cannot void 150 mils? Yes, this urodynamics may give further information, but again, that strength rating is weak. And in all of these scenarios, those in men where the Qmax is greater than 10 mils per second, a post-void residual of 300 mils, and then both extremes of age over 80 and less than 50, pressure flow studies or urodynamics can be done, but the evidence for doing this is weak. And this is a great study that was just published 2 years ago, and published by Marcus Drake, and it was a randomized control study investigating whether urodynamics would reduce surgery without increasing urinary symptoms bother. And this was done across England in 26 hospitals. 820 men were recruited, and 38% of them were in the urodynamics arm and went on to receive surgery, compared to 36% of men who had routine care and went on to have surgery. And what they found was that the urodynamics group was non-inferior to the routine care group, where they only had an IPSS score, and urodynamics did not reduce surgical rates. So their conclusion was this, that routine use of urodynamics in the evaluation of uncomplicated lower urinary tract symptoms has a limited role and should be used selectively. So we're not talking here about neurological disease, and that for neurological disease, it is absolutely recommended, for example, in spinal cord injury patients, that urodynamics gives us a baseline pressures of the bladder and ensures that we have a safe bladder. So I'm not talking about these patients here. So if we look at just these two groups, what is urodynamics adding? And upstream is saying that to be very selective, because it's agreeing with this recommendation that this is very weak, the strength of this recommendation. So what are we left with? We're left with, without urodynamics. How about this? Again, I've just taken this as a screenshot from the EAU guidelines, stating that the importance of assessing the patient's history is well recognized, taking in all of those symptoms, those storage symptoms, the voiding symptoms, various bits of the history that will enable us to make a good decision with the patient in front of you. Is there frequency, urgency, nocturia, urge incontinence, what we describe as storage symptoms? Is there difficulties with voiding, hesitancy, straining to void, stop-start flow? And we group this so that we can manage these symptoms better, with post-micturition dribbling being in a separate group. And of course, if there are any red flag symptoms of visible hematuria or recurrent UTIs, then absolutely this needs further investigations and shouldn't go down the LOTS pathway. More in the history. Is there stress? Is there urge incontinence? What about pad use? How does this affect your life? What about fluid intake? We know that the fluid intake is maybe restricted in the Sri Lankan population, where they're worried about where they're going to go to pass urine during their normal day if they're moving out of the home. How about bowel function and sexual function? All of these can be ascertained in the history. And how more can we assess them without using urodynamics? Well, we can use a bladder diary, a frequency volume chart. So we ask for this over 3 days, and we say, please write down everything you're drinking and pee into a jug. So measure how much you are peeing for every void for 3 days. And we also get basic flow rate measurements and of course the IPSS score. So then we can manage their storage symptoms with an overactive sort of discussion about how to manage their frequency, their urgency. And we talk to them about bladder training. And that is, for the men, 3 liters of water a day, and train your bladder to hold to 400 mils. 400 to 500 mils is normal bladder capacity, and we give them leaflets to help them to do this. And if we think back about bladder training and that detrusor overactivity, what we're asking them to do is manage this detrusor overactivity. So when they're getting that bladder spasm, or that detrusor contraction, if they can cross their legs, squeeze their pelvic floor, manage that spasm during that time, and hold on to their urine, they'll be able to train their bladder to hold for a bigger volume. Because what happens is, even without detrusor contractions, they start to want to pee, that sensation of needing to pee at a smaller bladder volume. So for those men who are concerned about peeing regularly, those just in case wees, just in case before I go out, I'm just going to go for a wee. Those are the sort of actions that we're trying to ask them to stop. And it very much manages the nocturia. So if they're getting up 2 or 3 times at night, voiding at 100 to 200 mils, we can absolutely say to them, train your bladder during the day so that your nighttime gets better. And by that we mean, if you are voiding at 100 to 200 mils during the day, then of course your bladder will wake up your brain when it hits 100 to 200 mils at night and say, go pee. So if you can train your bladder during the day to hold to 400 to 500 mils, your bladder will only wake you up at night when it gets to 400 mils. So that concept of training the bladder to help with nocturia symptoms, which is a key symptom that causes a lot of bother. And this is just the headline from BAUS, which is a bladder training information leaflet. So if you Google BAUS bladder training, this is a PDF document that you all can have access to. How about pelvic floor exercises? How does that play a role? Well, it absolutely helps to manage those storage lower urinary tract symptoms. So when they're having a detrusor contraction, if they can manage to squeeze their pelvic floor, then we know that they'll be able to manage that frequency and urgency and the urge-related incontinence better. And we know that men with bladder outlet obstruction do have detrusor overactivity present in 61%. So detrusor overactivity is quite common in men with bladder outflow obstruction. So teaching them how to manage their detrusor overactivity or the symptoms of their detrusor overactivity may play a very important role. And this is the BAUS information leaflet that you can access for pelvic floor exercises in men, which gives you a brief summary of how to tell your patients on where those muscles are and how to squeeze and train those muscles. And not to forget about pelvic floor relaxation. The pelvic floor is a group of muscles, and for any muscle, the normal state is of relaxation. So if it is constantly contracted, which it may be in pelvic pain or in anxiety and in stress, they need to learn how to relax the muscle before enabling a good pelvic floor contraction. And though I can't signpost you to BAUS for this, if you Google YouTube pelvic floor muscle relaxation, you will find many video clips that you can also signpost patients to. So to summarize, I've just briefly talked to you about the conservative management of lower urinary tract symptoms, really thinking about when to do urodynamics. And that is prior to invasive treatment, taking aside any neurological conditions that your patients may have, but a good history, a good bladder diary, and flow rate studies can give you a lot of information that simple invasive urodynamics can too. And I've also talked to you about bladder training and also about pelvic floor rehabilitation, that concept of relaxation, as well as pelvic floor muscle training. Thank you, and all the very best for the rest of the conference.